When you look at an adult anatomy textbook, I mean, everything seems so intentionally designed, like an engineer built it, right?
Yeah, completely. It all looks perfect on the page.
Exactly. The arteries run in these straight lines, the nerves branch exactly where they're supposed to, the muscles sit in their neat little compartments. But then, you step into the operating room, you open up a patient's neck, and suddenly that neat engineering goes completely out the window.
Oh, it's a mess.
It really is. You find like a random piece of thyroid tissue just clinging to the back of the tongue, or a nerve that decides to take this massive illogical detour down into the chest around a major artery just to get back up to the neck where it started. It is the absolute definition of an anatomical crime scene.
Well, what you're actually looking at is a map of fetal development, just frozen in time. I mean, the adult body is simply the end result of tissues migrating. They drag their blood supply and their nerve connections with them, and sometimes they just leave fragments behind.
Right. Well, welcome to this MRCS revision deep dive. Designed specifically for you, the surgical resident, we are jumping straight into the action today.
No time to waste.
Exactly. This session is a rapid-fire Q&A style review of high-yield anatomy. We're covering the head, the neck, and the spine. But before we map out these surgical planes, hit follow right now to ensure you don't miss future revision deep dives. And if you learned something valuable today, please rate the show.
Yeah, it really helps out.
And specifically, head over to medsynclimited.com. That is medsynclimited.com to get your surgical simulation kit. It includes a suturing kit, the microsurgery instruments, basically everything essential for practicing the exact skills and planes we are discussing today. Do not waste time. Get your hands moving while your brain absorbs this.
Best way to learn, honestly.
So let's start before birth, because understanding complex adult structural anomalies, it requires mapping how they actually formed in the embryo.
Yeah, the branchial arches are prime testing territory for exactly this reason. They lie in the side walls and the floor of the fetal pharynx.
Right.
And, each arch comes with its own skeletal element, an artery, a nerve, and striated muscle.
So break down the first and second branchial arches for us.
Sure. So for the first arch, also known as the mandibular arch, the designated nerve is the trigeminal nerve, cranial nerve 5. Because of that, it gives rise to the muscles of mastication. And skeletally, it forms the incus and the malleus in the ear.
Okay, and the second arch is the hyoid arch, which corresponds to the facial nerve, right? Cranial nerve 7.
Exactly. And that explains its connection to the muscles of facial expression. And skeletally, it forms the stapes, the styloid process, and the upper part of the body and lesser cornu of the hyoid bone.
So I'm trying to picture the tongue in relation to all this. It feels less like a single organ and more like an anatomical patchwork quilt,
Yeah.
just stitched together from all these different developmental zones.
That is a perfect way to think about it. And you
Yeah.
can actually see the seams of that patchwork when you look closely at its nerve supply.
Right, because of the sensory divisions.
Yeah. The anterior two-thirds of the tongue develop from the first and second branchial arches. The trigeminal nerve, via its lingual branch, handles general sensation there.
Right,
Meanwhile, the facial nerve, via the chorda tympani, handles taste.
got it. And the posterior third?
That develops largely from the third branchial arch, where the nerve is the glossopharyngeal nerve, cranial nerve 9. And that handles both general sensation and taste for the entire posterior third.
But the muscles of the tongue don't actually originate in those arches, though. I mean, I recall reading that they migrate from somewhere else entirely, which always seemed like an unnecessary developmental complication.
It really does seem overly complex. The tongue musculature is actually derived from migrating occipital myotomes.
Wow.
Yeah. They migrate forward during early development, and as they travel that vast distance, they physically drag their nerve supply with them.
Which is the hypoglossal nerve, cranial nerve 12.
Exactly. So the sensory skin of the tongue is a local branchial arch patchwork, but the motor engine is imported all the way from the occipital region.
That's wild. Well, the thyroid feels like another classic example of migration creating surgical hazards.
Oh, for sure.
It develops as a diverticulum from the floor of the embryonic pharynx right at the site of the developing tongue, which in the adult is the foramen caecum.
Right, that's the origin point.
And from there, it grows caudally. It descends superficial to the branchial arches, the hyoid, the larynx, down to its definitive position in the neck. I know the trail it leaves behind is the thyroglossal duct, which is supposed to disappear.
Supposed to, yeah.
But if traces remain, they form thyroglossal cysts. So why is it a strict surgical rule that we must excise the body of the hyoid bone along with the cyst to prevent recurrence?
Well, it comes down to literal physical entanglement. During development, as the thyroid descends, the hyoid bone is forming and rotating at the same time.
Ah, so they get mixed up.
Exactly. The thyroglossal duct becomes incredibly intimately associated with the body of the hyoid bone. Sometimes it passes anterior to it, sometimes posterior, and sometimes it just goes straight through the developing cartilage.
Right, so you can't just scrape it off.
No, you simply cannot guarantee you removed all the epithelial remnants of that duct unless you take the central portion of the hyoid bone with it.
Makes sense. And if the thyroid never makes the downward journey at all?
Then that aberrant tissue remains trapped at the origin point at the foramen caecum, presenting as a lingual thyroid.
Okay, moving on to the spine. The spine has a similar developmental mismatch, doesn't it? The bones and the nervous system do not grow at the same pace.
They don't. And that radically alters our landmarks for procedures. Up to the 3rd month of fetal life, the spinal cord occupies the full length of the vertebral canal.
But then the bones just take off.
Yeah, the vertebral bones start growing much more rapidly than the spinal cord itself. The bony canal elongates, but the cord gets left behind, drawn upward relative to the bones.
So at birth, the cord terminates at the level of the 3rd lumbar vertebra, L3.
Exactly. And then by adolescence, the cord has reached its definitive adult position, terminating much higher, usually at the disc between L1 and L2.
Which strictly dictates the safe zones for lumbar puncture. I mean, we have to be well clear of the termination of the cord, so we use the intercrestal line, a line joining the iliac crests, which passes through the 4th lumbar vertebra.
Right, so the intervertebral space above or below L4 can be safely used.
Though below is always safer in babies and young children, given that their cord might still be hanging around L3.
Absolutely.
This concept of fetal growth dictating adult boundaries really hits home when you look at the skull base, too. I mean, I always hit a wall trying to memorize the middle cranial fossa foramina. Why on earth does the trigeminal nerve need 3 separate exits instead of just one main trunk?
Well, it requires separate exits because it serves 3 entirely distinct developmental regions of the face.
Break those down for us.
Okay, so the superior orbital fissure transmits the ophthalmic division, V1, alongside cranial nerves 3, 4, and 6, plus the ophthalmic veins, riding straight into the orbit.
Right, and then V2.
The foramen rotundum transmits the maxillary division, V2, directing it forward into the pterygopalatine fossa to serve the midface.
Got it.
And the foramen oval transmits the mandibular division, V3, dropping it straight down into the infratemporal fossa for the lower jaw.
What about the foramen spinosum?
That one is unrelated to the trigeminal. It transmits the middle meningeal artery into the skull to supply the dura.
Okay, so in the stress of an exam or a messy trauma case, it can be easy to blow the roles of the trigeminal and facial nerves on the face.
It's a common stumbling block, yeah.
I find it helpful to think of the trigeminal nerve strictly as the face's sensory grid, supplying the skin via those 3 distinct V1, V2, and V3 dermatomes. And it powers the muscles of mastication, stemming directly from its first arch origins.
Right, whereas the facial nerve is strictly motor when it comes to the face. It supplies the muscles of facial expression due to its second arch origin.
So how does that look clinically? Like if we're looking at a facial nerve lesion?
You see the distinction really clearly there. Take the orbicularis oculi muscle, for example. The palpebral part of this muscle sits in the eyelid and is responsible for closing the eye.
Okay.
When the facial nerve is paralyzed, muscle tone is lost entirely. The lower eyelid physically falls away from the eye, drooping downwards.
Wow, so without that tight seal.
Exactly. Without the seal, tears cannot be swept into the lacrimal puncta, so they just constantly drain over the cheek.
That's a great clinical tell. Let's talk about the center of the face. The central area is medically termed the dangerous area for a pretty terrifying reason related to venous drainage.
Very terrifying.
The main vein draining the face is the facial vein. Now, I know this vein communicates freely with the veins of the orbit, specifically the ophthalmic veins, which in turn drain directly back into the cavernous sinus inside the cranial cavity.
And crucially, these veins lack valves. Blood can flow in either direction depending on pressure gradients. So a superficial infection on the nose or the upper lip has a direct, valveless highway straight into the cranial cavity.
Which creates a direct route for pathogens to spread inward and cause a cavernous sinus thrombosis.
Exactly, turning a simple skin infection into a life-threatening neurological emergency.
Okay, so following those cranial nerves out of the skull leads us directly into their highly specialized target organs. Let's start with the orbit. The classic LR6 SO4 mnemonic is drilled into every medical student.
It's a classic for a reason.
It tells you that the lateral rectus is innervated by cranial nerve 6, the abducens nerve, which makes perfect mechanical sense because it abducts the eye.
Yeah.
The superior oblique is innervated by cranial nerve 4, the trochlear nerve, and every other extraocular muscle is supplied by cranial nerve 3, the oculomotor nerve. But the superior oblique always trips people up. Mechanically, how does it manage to depress, abduct, and immediately rotate the eyeball all at once?
Well, it acts through this biological pulley system. The muscle belly originates at the back of the orbit, but instead of attaching straight to the eye, its tendon runs forward and loops through a fibrous ring called the trochlea.
Which is on the medial roof of the orbit, right?
Yeah, right. And then it turns sharply backward and downward to attach to the top back portion of the eyeball.
Okay, I'm picturing it.
So when the muscle contracts, it pulls the back of the eye upward and inward toward the pulley. Because the eye is a sphere pivoting on a central axis, pulling the back of the eye upward forces the front of the eye downward, causing depression.
Ah, and pulling the back
It
inwards.
forces the front outward, causing abduction.
That makes so much sense when you visualize the pulley. Okay, moving from the mechanics of the eye to the mechanics of the inner ear.
A very different fluid dynamic.
Right. The membranous labyrinth is floating inside the bony labyrinth. I have always wondered how the fluid inside manages to differentiate between knowing your body is actively moving versus just knowing your head is tilted sideways while you're sitting still.
The architecture is basically split into two distinct sensory systems. First, you've got the semicircular ducts. They are disposed in 3 planes at right angles to each other, representing the X, Y, and Z axes of 3-dimensional space.
So as you move.
As you move, fluid lags behind in these specific rings due to inertia, and that bends the hair cells. This conveys a sense of dynamic motion. It tells your brain where you are going.
And for static position.
That's the utricle and the saccule, located within the vestibule. They rely on gravity rather than fluid inertia. They contain tiny calcium carbonate crystals sitting on top of hair cells.
Oh, right.
So when you tilt your head, gravity pulls on these crystals. This conveys a sense of static position. It tells your brain where you are relative to the ground.
That's a great breakdown. Let's move down to the larynx, which presents one of the highest stakes anatomical landscapes during surgery, particularly during a thyroidectomy.
Absolutely.
The recurrent laryngeal nerve has always baffled me.
Right.
Why does a nerve destined to supply the voice box in the neck take a massive perilous detour down into the chest just to loop back up?
That is the ultimate embryological ghost. Early in fetal development, the heart and the major vessels form high up in the neck region, and the vagus nerve gives off branches to the branchial arches. The nerve to the 6th arch loops under the 6th arch artery. But as the fetus grows, the heart descends into the thorax, pulling those major vessels down with it.
And the nerve gets caught.
Exactly. On the left side, the 6th arch artery becomes the ductus arteriosus, linking to the aortic arch. On the right, it becomes the subclavian artery. The nerves are physically caught under these descending vessels and are dragged all the way down into the chest.
Forcing them to recur or travel back up the neck to reach the larynx.
Precisely.
And that detour puts them in extreme danger when we are operating on the thyroid. We have to consider the upper and lower poles of the gland separately, right?
Right. Let's start with the upper pole.
At the upper pole, you have the superior thyroid artery. And lying very close to this artery is the external branch of the superior laryngeal nerve.
Yeah, you have to be very careful there.
If you accidentally ligate or damage that external branch while securing the upper pole, you lose the motor supply to the cricothyroid muscle.
Which is critical because the cricothyroid is the only muscle that tenses the vocal cord. So the patient will experience a permanent drop in their voice pitch.
And then down at the lower pole, you face the inferior thyroid artery, which is intimately tangled with that recurrent laryngeal nerve we just discussed.
Right. And this nerve supplies all the other intrinsic muscles of the larynx.
So what happens if you damage it?
Well, if you damage the recurrent laryngeal nerve on one side, unilateral damage, the affected vocal cord is paralyzed somewhere between abduction and adduction. The functional clinical result is severe hoarseness.
But bilateral damage?
Bilateral damage is a catastrophic breathing emergency. Both cords lose their motor control and fall into a paramedian position, basically sitting partially closed.
So they completely lose their voice.
They lose their voice, and they experience severe respiratory stridor as they try to pull air through a drastically narrowed glottis. It's terrifying.
Yeah, that's a nightmare scenario. Okay, zooming out a bit, the whole neck is organized into these rigid fascial cylinders that contain all these migrating structures and neurovascular bundles.
A fascial planes.
The outermost cylinder is the investing fascia. It envelops the entire neck like a collar, splitting to enclose muscles like the sternocleidomastoid and the trapezius.
And the clinical danger here arises with the external jugular vein, which pierces this investing fascia just above the midpoint of the clavicle.
Right. Why would the body design a fascial layer that actively holds a severed vein open? I mean, that seems like a fatal design flaw.
Well, in a healthy, intact state, it makes sense. The deep fascia is tethered to the vein wall to prevent the thin-walled vein from collapsing under the negative pressure generated by the thorax during inspiration.
Ah, so it maintains venous return normally.
Exactly. However, if that vein is surgically or traumatically divided at the point where it pierces the fascia just continues doing its job.
It acts like a stent.
Right? Physically holding the lumen of the cut vein open. And because venous pressure drops below atmospheric pressure during a deep breath, air is sucked directly into the open vein
Traveling straight to the right side of the heart.
and causing a potentially fatal air embolism.
The fascial roof of the posterior triangle creates a different kind of hazard. If you are doing a superficial lymph node biopsy in the posterior triangle, the spinal accessory nerve, cranial nerve 11, is extremely vulnerable.
Very vulnerable.
After it passes deep to the sternocleidomastoid, it enters the posterior triangle and lies very superficially. It is literally embedded in the deep cervical fascia of the roof as it travels across to reach the trapezius muscle.
So a scalpel going just a millimeter too deep will sever it.
Yeah.
That paralyzes the trapezius, and the patient presents with an inability to shrug the affected shoulder.
Okay, going deeper to the root of the neck, we encounter the phrenic nerve.
Yes, a crucial landmark. It forms at the lateral border of the scalenus anterior muscle.
And its path is what we really care about, right?
Right. It passes inferiorly, running straight down on the anterior surface of the scalenus anterior, plastered right behind the provertebral fascia. This specific location is a vital landmark when you're navigating the deep structures of the lower neck.
Okay, following that fascial organization backwards brings us to the central pillar protecting the entire spinal cord, the vertebral column. If you hand me a random vertebra, identifying its region comes down to its functional adaptations.
Absolutely.
Cervical vertebrae have the foramen transversarium, the hole in the transverse processes. And this isn't just a random hole. It forms a continuous bony tunnel to protect the vertebral artery as it travels up to supply the brain.
And then the thoracic vertebrae.
They feature cospal demifacets on the sides of the body where the ribs articulate, which are, essential for the bucket handle mechanics of breathing. Plus, they have those long, downward sloping spinous processes.
Right.
Lumbar vertebrae, on the other hand, have massive thick bodies and strong, square, horizontal spinous processes designed to support the entire weight of the upper body.
And that massive weight-bearing role in the lumbar spine is exactly why disc herniations are so common there.
Yeah.
The mechanics of a slipped disc require visualizing the three-dimensional space of radiculopathy. The intervertebral foramina, where the nerves exit the bony canal, are positioned laterally.
Right.
A typical disc prolapse is paracentral, meaning it protrudes backward and slightly to the side, passing just lateral to the tough posterior longitudinal ligament.
Now, this creates a confusing paradox for residents. An L4, L5 disc herniation is physically located below the L4 vertebra, yet it usually compresses the L5 nerve root instead of L4.
It's unintuitive.
Yeah, why does it miss the nerve right next to it?
It is entirely about the geometry of the exit routes. At the L4, L5 level, the L4 nerve has already moved laterally to exit through its intervertebral foramen.
Oh, okay.
So by the time a paracentral disc protrusion pushes backward into the canal, the exiting L4 nerve is already out of the way. The protrusion misses it entirely.
However, it catches the transiting L5 nerve root.
Exactly, which is currently traveling down the inside of the spinal canal, getting ready to exit at the level below.
But if the herniation is far lateral instead of paracentral, the mechanics shift completely.
They do. A far lateral disc herniation pushes straight into the intervertebral foramen itself.
So in that confined space, it will directly crush the exiting nerve root against the bone.
Right, which in the case of an L4, L5 far lateral herniation would be the L4 nerve.
Okay, we differentiate these nerve compressions clinically by mapping the specific deficits. An L5 lesion, say from an L4, L5 paracentral prolapse, will cause profound weakness in ankle dorsiflexion and big toe extension, alongside numbness over the lower lateral leg and medial foot.
But an S1 lesion, typically from an L5, S1 paracentral prolapse, presents a different mechanical failure.
What are we looking for there?
You'll find a diminished or entirely absent ankle jerk reflex, weakness of the foot everators, and numbness extending over the lateral side of the foot.
Got it. And what if a massive disc prolapses directly backwards, perfectly central?
Then it bypasses individual nerve roots entirely and compresses the entire cauda equina within the sac. This is an absolute surgical emergency.
Because they'll present with saddle paresthesia.
Reduced anal sphincter tone and painless bladder retention with overflow. The pressure must be relieved immediately to prevent permanent neurological destruction.
That brings us to the end of our rapid-fire review. I want to leave you with a final, provocative thought to mull over. Consider how the embryo's developmental pathways strictly dictate adult surgical planes. What seems like arbitrary adult anatomy, like a cyst tethered to a hyoid bone, or a nerve looping around an artery deep in the chest just to supply the vocal cords, is not random at all.
No, not at all.
It is simply a chronological map of fetal development frozen in time. As you study, ask yourself, what other embryological ghosts might be hiding in plain sight in your surgical field?
Recognizing those ghosts changes the way you look at the human body.
Yeah.
You're not just memorizing structure. You are reversing the engineering of fetal growth.
Before you go, we want to hear from you. Leave a comment or a question below regarding your biggest MRCS anatomical stumbling block. What is the one area you always have to reread because the development just doesn't make sense? Make sure you follow the show, review the facts we discussed today, and keep practicing those clinical applications. Thanks for joining us on this deep dive. See you next time.